So what are the goals of a J-pouch procedure? And I always say to the patients, and think about, what is a pouch meant to do for you? Number one, get rid of ulcerative colitis. Number two, get off all IBD meds, and that's steroids, biologics, etc. Importantly, restore bowel continuity so there's no permanent ostomy. But extremely important, and I feel often most important, is improve a patient's quality of life. And again, as I said before, it requires patience, self-management during the adjustment phase. 90% of patients are happy with the results and would recommend to others. Now, the expectations, I give this to my patients and I tell them, you take this home, you frame it, and you put it somewhere where you can look at it every day. Because what they tend to do is bowel movements start creeping up, or they forget about all this information to where good function is, and they start accepting bad function. So usually 4 to 8 stools per day. That can be right in the beginning, but where I want them to stay and keep themselves is at 4 to 6 a day. And if that means using Imodium, we're going to use Imodium. We want thicker to pasty consistency. Occasionally formed, I don't see them getting a lot of formed stools, but surprisingly, some of the young kids, the teenagers or whatever, they can do it sometimes. But what I want them to achieve is 80% of the time a thickened stool, at least applesauce oatmeal. They can have one nighttime bowel movement, and that again is because if they're eating later at night, they're going to have one. So we're going to talk about that, how we can try to eliminate that as well. And sometimes it's taking Imodium before bed. Delay a bowel movement. Initially, it might be like 30 minutes, but over time, as they are able to hold their bowel movements longer, it can get up to an hour. And I've seen it where it is 4 hours for some patients. No stool urgency or tenesmus. If they're getting that, then I'm wondering, are they having like that cuffitis or some irritation down in the anal area that's causing that? Maybe and maybe not. Can they pass gas without losing stool? Some can do this. Some it takes time, and over 6 months or maybe more, sometimes they can. Some never can. And some absolutely outright tell me, Michele, I don't even try, because I know there might be a little spurt or something, so I don't even try to do that. And some will also say that when they lay down, they can pass gas better as well. Most have no leakage of stool if present at night. And again, that's because they're in a deep sleep. And for some, it's only a wetness. It's not an outpouring of stool. Initially in the post-op hand sewn technique and in older patients, we may see that initially in the beginning. Perianal use of moisture barrier ointments as needed. That's of utmost importance if they're having leaks or if they're having a lot of loose stools for whatever reason, maybe how they ate or drank, whatever. Eventually, they can eat most foods. And some will say, I don't have any trouble with anything. I just kind of, I don't have any issues. And others will say spicy foods cause me irritation, high roughage, high sugar or coffee increases my stools. But eventually what they say is, you know what, Michele? I pick and choose when I'm going to eat these. I'm going to do it maybe when I'm home on the weekend. It's summer. I want some corn. I want to try a little bit of corn. So they'll do it on a weekend, whether they're not at work, but they're at home. Maybe they're around, a bathroom more, and they'll choose and do it then. And that's fine. And then they get back into eating the foods that they know get them back into their norm. But the most important thing to remember and to tell patients, function improves over time. 3 months, 6, 9, 12 months, and can up to 2 years for some people. I would say within the first year, pretty much most things have settled into where they're going to be. But it's very important to let patients know it's not right off. It's not everything 100% wonderful, normal right off the bat. It takes time, and eventually they will get there. So initially after a bowel movement, in that adjustment phase, again, those initial bowel movements may be a little more frequent, they may be loose, and they may be prompted by gas. And that's because right after surgery, things starting up, the pouch hasn't really been filling with stool or anything, so they may notice a little bit of that. So they need to focus on those high starch foods, salty snacks, because that holds in water, applesauce, bananas, etc. Those are all the things that are going to thicken their stool. I also tell them, do not drink on an empty stomach. They need to eat first, then drink. You know, they can snack or whatever, but if they just drink, it's going to go through them quickly. Kind of like, you know, when they have the ostomy, I talk to them about, you know, think of from your mouth to your stoma or wherever, think of that like a pipe. How it goes in your mouth is how it's going to go out. So if all you do is drink, it's going to rush right through you. And it's going to do that a little bit with a J pouch, obviously a little better because you have a pouch that now is acting like your rectum, but it can still loosen the stool. So we always say, try and eat first, then drink. And don't be guzzling a gallon of water at one time either, because some do that. And it's like, they're going to be looser, you know, that's the water. And I tell them, keep the stools below 10. Again, 5 to 6 best. One night time is common. And again, using the anti-diarrheals, 1 or 2 tabs before meals and bedtime. Maximum is 8 a day on the Imodium. But, you know, try 1 tab initially, and if they need 2 tabs, fine. Sometimes they maybe only need it at bedtime to keep the bowel movements down, and then maybe in the morning to start the day off right. And some need it for every meal and at bedtime. I always tell them, do not read the box of Imodium because it tells you, you know, take it PRN whenever you have a bowel movement or whatever. Well, that's not correct with this. The other thing is a lot of their insurance companies do not pay for the loperamide or Imodium. And you can't get them, you know, the boxes only contain a small amount that they sell in the pharmacies. And that's because some kids ruined it for patients who really needed it because they crushed them up and were snorting it. And when that happened in the past here, they could no longer get a large amount. However, they could order it on Amazon, can get it at Target, maybe even Costco, and they can get a larger bottle of the Imodium because one at the pharmacy is not going to last them long at all. The other thing is, do not eat the biggest meal at night or late. I always tell them, eat your bigger meal before 7 o'clock. Otherwise, you're going to really have, that's going to make you get up more at night. Now, you can snack a little bit, that's fine, but not a big meal. Urinary function, a lot of them will tell me that they may pass stool when they urinate initially, and that's okay because, you know, that's next to each other there. The bladder and the pouch and those nerves are all there, but that usually separates and it's fine later on. Sexual function, as I had mentioned before, the dyspareunia, the weak erections, see this initially, but give it around 6 months. A lot of times this, you know, settles out and it improves and gets better. The other thing is, you need to talk to these patients about no anal sex. Because you can imagine, you know, I tell them that is prime real estate down there. You mess with that or messing with the sphincters down there, you're going to get leakage. So I say no anal sex. The other thing, if they do have stool leaks, they need to use moisture barrier ointments. You know, any diaper rash ointment, Calmoseptine, any of those things that are out there, Aquaphor, particularly when they're having looser bowel movements or when they know they're going to be looser, you know, kind of prepare ahead of time. Like some patients say, I'm going to go out drinking with the guys or the girl, whatever. And I say, you know what, before you go, prepare. Make sure that you got your moisture barrier ointment on so that if you are having looser stools, you already got some preparation there. But I also tell them you got to snack when you drink, you know, have something there that you're snacking on. The other important issue is these butterfly or anal incontinent pads. And what they do is they fit between the buttocks and that protects the skin because it wicks the moisture away. You know, they all want to come with panty liners. And I'm not, nope, panty liners protect your clothes. That's okay. But when you're having leakage or things you're worrying about, you need to have those butterfly incontinent pads there. Use wet ones instead of toilet paper. That, because that frequent wiping with toilet paper can be kind of harsh. So I always say use wet ones. Obviously, though, here, the best thing and what so many of my J pouch patients have now are the bidets. That is like the best thing ever. They're there and it just cleans everything well, dries it if it's got the blower there. But that is absolutely perfect. And all my J pouch patients swear by it. Acidic foods, obviously, that can cause burning discomfort in the anus. So they need to understand that and could prepare for that as well. Initially, you're going to have some pouch spasms because this pouch is going to stretch in the beginning to hold stool. Because remember, it's been there now for like 3 months before. It's just sitting in there, only secreting a little mucus. And there's been no food. So now that you're actually eating, the pouch is going to stretch to hold stool. So they do feel that spasming. That goes away fairly quickly. In some, it's more bothersome, and then I'll give them an antispasmodic. But that's normal in the beginning, and they should expect that, and it will go away. I always have them do a full food and stool diary. I think that is so helpful for a week because they can document a little bit what they're eating and when they're having the bowel movements and the consistency at the time. I find that I have them do that because if you just ask a patient, okay, well, how many times are you going to the bathroom a day or what's going on? Oh, I think it's this or that. And then I'll have them do a week diary. Oh, well, I guess it is a little different. So I find those diaries are very important. But again, the key is a pouch adapts over time. And you really have to establish realistic goals with the patient. Now, here are the supportive treatments. I talked about the anti-diarrheals. You could use bulk formers. Some may need a bile salt binder. If you notice that the stools are floating, they're airy, they're a little, sort of a light tan color, and they're just frequent and a lot and liquidy, maybe they have a bile salt binder. Because particularly if they've been doing everything right and that isn't working, that could be an issue. Antispasmodic agents, acid reducing drugs, and we always put our patients on omeprazole after surgery for a couple of weeks. Any surgery, we actually do that, and I find it's very helpful. Anal leakage pads, perineal ointments, and they need to be moisture barrier. And you want to be sure that you tell them apply it to dry skin, because if it's wet skin, you're going to hold the moisture there, and then you're going to end up with an antifungal. So then antifungal ointments can come into play. The other thing is they need to be taking their iron, vitamins, minerals, whatever they've been taking, they need to continue to do that. Here is what I assess at every visit. Their bowel movements, the number, they have them at night, the consistency, all important aspects. Do they have leakage of stool? And when is it? Is it actual stool or is it just a little wetness? Are they wearing the anal leakage pads? Are they using the ointments there? Perianal skin integrity, is there skin loss, erythema, denuded skin, fungal infection? That's always look at that. Ileoanal anastomosis at every visit, every 3 months, I am doing a digital exam to assess the patency because particularly if it's the hand sewn, it could narrow down, maybe, but always check it. And at the same time, you're gonna do the squeeze tone. Have your finger in there, tell them to squeeze, then relax, have them squeeze again. Sometimes that first one isn't, they're kind of figuring out, am I squeezing right or whatever? So you want them to do it a couple times so you really do get the tone. Quality of life, is it interfering with work, their daily routines? Are they able to sleep at night? Or are they getting up because they got to go to the bathroom? How is their diet? Are they exercising? How's the relationships? Depressed, anxious, PTSD, all of those things. And I find that if patients have that with the ulcerative colitis, when they do that, it doesn't automatically go away. So we still have to assess those factors because again, everything isn't wonderful right away. And it's not, quote, normal what they think of normal, but they find their new normal, which is actually good and they can help manage, and that may take a year. Sexual function, again, we talked about the dyspareunia, ability to reach an orgasm, ability to get pregnant. One thing I can say there that After this surgery, we usually say, why don't you at least wait maybe up to a year, 9 months to a year before you get pregnant, because I want them to find what their new norm is going to be. And in this transition phase in the beginning, there's going to be ups and downs and they got to try different things. I want them to know what their function is going to be like and how to manage issues when they come up. So that's why I kind of want them to wait on that. The other thing, it's important to note that when they are pregnant and the baby is getting large, over the last 3 months or whatever, they will have more bowel movements because, the baby's pushing on that area. But after they deliver, they'll be fine. They'll go back to their normal. And the other thing is, when they're pregnant, we really recommend a C-section, particularly if there's any high-risk issues, because we don't want them getting an episiotomy because, again, that's prime real estate down there. Don't mess with it. So we recommend they get a C-section. But I'm telling you, I've had, a woman who just delivered like that quick, had no chance, and she did fine. She did okay. There wasn't any complications. So it can be happened, but why should we take that risk if we don't have to? In men, the erectile function, ability to reach orgasm and ejaculate, this also improves over time. It could be 6 months. And if not, I refer them to a urologist. And the pill works. It definitely works in these patients. And then use of anti-diarrheal medication, fiber preparations, like I said, the bile salts, binders. And if they're on NSAIDs, don't want them on NSAIDs because that can bring on pouchitis in these patients as well. Antibiotic use, want to ask about that. Are they on antibiotics? Because some may give them more diarrhea, but others are absolutely fine. But I want to know if they have had pouchitis and they're still on it or what's going on. So here are the complications. Pouchitis, the biggest, 50% overall. Cuffitis is small. Anastomotic complications, and when I talked earlier about it, you want to know, is this Crohn's or is it surgical issue? If they have the pouch fistula, the sinus tract, the leaks, was that from Crohn's or was that a leak from the surgery? The other thing is, before we take the stoma down in that third step, we do a dynamic proctography, or you call it a barium enema, and that is to assess that there is no leak at the anastomosis, and that's very important. Most of the time, there's no issues. Once in a while, we may find one. We just give it more time and it heals. Anastomotic strictures, I talked about it. Crohn's disease, very small, 10 to 13%. Develops later on, usually. The complications, some of these that begin right away after surgery, that might be due to the surgery. So Crohn's disease usually develops later on, and it can result in pouch failure. Pelvic vein thrombosis, small, but as with any surgery, blood clots are an issue. That could result in pouch failure. Dysplasia or neoplastic, very small, but remember, it's if it does occur, it's going to be in that cuff with the stapled technique. And so we need to know, where was that cancer or dysplasia noted? Because if it was in the sigmoid or lower, we really would recommend more of a hand sewn if at all possible. Twisted pouch syndrome, mentioned that before. I'll show you in the next slide what that looks like. That's extremely rare, but I've seen a little bit more of it in the last year or so. Sexual dysfunction, again, we talked about it. Laparoscopic approach has definitely reduced those dysfunctions. But I'm going backwards. What's wrong with me? Here's the twisted pouch syndrome. The normal you see is the first one, and then this is variations. Now, they sometimes, when they form the pouch, it's a little bit, moved or twisted a little bit. But more recently, for whatever reason, we've seen these twisted pouch things. And how we finally sort of can identify it, I'm going to talk about it here. So it's rotated in the pelvis, usually at the time of construction. But that could happen a little later on. Maybe it's due to adhesions pulling in a certain area and causing that. Common symptoms are severe abdominal pain. They may have pelvic pain, difficulty passing stool, erratic bowel movements, needing to poop more than 10 times a day, even though they're doing everything right. And then there may be a time where they're actually okay. And then they get like these partial obstructive symptoms. And of course, you got to do all the testing, check the pouch, the dynamic proctography, barium enema kind of thing, and see if you can find it. And to be honest, sometimes you don't see these. And I feel like whatever it then flows or does whatever it's supposed to do, and then at another time it'll turn and twist. The only way to fix this really is reoperation. Here are symptoms of ileopouch disorders: diarrhea, urgency, cramps, bleeding. Okay, what are we going to do? Pouch endoscopy, with histology for sure. Check a fecal calprotectin and see if that is elevated, because often it's going to be elevated with inflammation. But what could it mean? Pouchitis, cuffitis, Crohn's disease, irritable pouch syndrome. Those are the things that you want to try and figure out with those symptoms. The other one, dyskinesia, incomplete evacuation. There you got your contrast enema, dynamic pelvic MRI, etc. And so this could be related to just it's emptying issues. They can't evacuate. Even an irritable pouch syndrome, that could be something with J pouches as well, that they may be emptying out a lot and having the cramping, whatever. And then you can sometimes get that dysfunctional mega pouch. And often I've seen that periodically too. It's when the pouch sort of gets big and it kind of falls back a little bit. And so they can't get a direct empty out because it's kind of fallen back a little and it's sitting there and then it has to spill over. So those are all kind of, evacuation issues and motility issues that can occur. And I have had to have some patients to self-irrigate their pouch. And, they're at home and they're instilling, water, sterile water, and trying to empty out to get it to overflow to get it with an irrigation. And some people are okay doing that. I just, they don't mind. They don't want to go back to a stoma, but I do have a couple that will do that. Nausea, vomiting, bloating, do the abdominal x-ray, small bowel series, CT, contrast enema. Often, is this a small bowel obstruction? Is there a J pouch stricture at the anastomosis or above the pouch? And the different limb syndromes that aren't really allowing the emptying process either. Fistula, drainage, perianal pain. Again, do your usual MRI, contrast enemas. For the fistula, the drainage, perianal issues, always we do an exam under anesthesia. And then the thought process is this Crohn's disease? Or are these just post-op leaks? Is there a pouch sinus? Is there an abscess? So again, pouchitis, most common. Pathogenesis, abnormal mucosa immune response. There's alterations in the mucosal and luminal microflora in genetically susceptible patients, or there's a break in the cell barrier wall. So there's an imbalance in that intestinal ecosystem, and that's what pouchitis is. And why that's supported by occurs only after restoration of the fecal stream. Fecal stasis due to anastomotic strictures or pouch emptying disorders can cause it, and it does respond to antibiotics. Here are the potential risk factors: the extensive UC, backwash ileitis, extraintestinal manifestations, again, like particularly primary sclerosing cholangitis. If a patient has that, 80% of them have pouchitis, and that's one thing we definitely have to talk to those patients about. Most likely you're going to have it on a chronic basis, and you're going to have to be on antibiotics or other drugs. Prior abdominal pelvic surgeries, you have to think about a strictured anastomosis. That causes the ischemia and the stool stasis. Non-steroidal and anti-inflammatory drugs, we've talked about the NSAIDs. Being a smoker increases the risk of acute pouchitis. Can maybe decrease the risk of chronic pouchitis, but obviously that was because they were smoking. Younger age at time of proctocolectomy, and that's just related to the length of follow-up. The longer you have the pouch, you're a little higher risk maybe of developing it. Then there's the genetic polymorphisms in IL-1 and NOD2, and then non-carrier status of TNF L3. I'm sorry, L2, and combined carriership of those other alleles. And the relationship between pouchitis and T helper cytokines in the ileomucosa. There's this expression in the normal ileomucosa at the time of colectomy may be important in the pathophysiology of pouchitis. So we're always continually learning about it. Classic symptoms, again, watery bowel movements, urgency. All patients say it feels like ulcerative colitis. Again, that's how they know. They may or may not have blood in the stool unless they've had it for a while and they've got some, real ulceration going on in there, or the cuff. That can be a sign that there's bleeding at that cuff if they had a stapled. May or may not have fever, leakage of stool, dehydration, obviously, if they're having a lot of stools, and sometimes those extraintestinal manifestations. That can be, can let us know that, oh, all of a sudden they're getting these joint pains and things, and now they have pouchitis. They can sometimes go hand in hand. Again, talked about 50% of patients develop one episode, 80% may develop one episode at 30 years, occurs usually after 6 months, haven't found it occurring before that. So when they're having looser stools and whatever, and initially, I'm always thinking, okay, how are you eating and drinking? Are you really focusing on thickening your stools? Did you eat something that really set you off? So I'm always looking in that first time frame, is it how they're really adjusting to getting thicker stools? Or have they come down with a flu or something that, there's somebody else sick in the family? Maybe that's what's going on. So I don't always ever assume that it's pouchitis in the first 6 months. I check out what else could it be, or are they on NSAIDs? There you go, another one. 60% develop 2 or more episodes. 10 to 19% develop a frequent or chronic pouchitis. And those are the ones that are a higher risk of losing their pouch. Here's a normal ileal pouch. Here's the different many faces of pouchitis. You can see the ulcerations in there. And we have the modified pouchitis disease activity. Clinically, you're looking at stool frequency, and the score there that you're looking at is greater than or equal to a 5. That would tell us it's pouchitis. And so you're adding up, looking at stool frequency, rectal bleeding, the fecal urgency, abdominal cramps, fever, and then the endoscopic inflammation. You get a point for having edema, granularity, friability, loss of vascular pattern, mucus, exudates, and ulceration. So all of that we can use for the pouchitis disease activity index. All right. What am I doing here? All of a sudden, I lost my ability to. There. So what else do we know with pouchitis? Fecal calprotectin, if it's greater than 56, predicted pouchitis within 2 months. And you can see with the PDI score and endoscopic score, they could predict it within 2 months prior. So the fecal calprotectin is a good one. How do we treat it? Acute pouchitis, usually a 2-week course of either Cipro or Flagyl. I tend to go with Cipro first because a lot of patients don't really tolerate the Flagyl so much. They get that metallic taste. They don't feel like they like it. So I kind of go with that first. And I think Cipro may be a little bit more effective at times than the Flagyl. Other things you can use is the rifaximin. Sometimes that's got a high price to it. Augmentin, if intolerance to Cipro or Flagyl, or if a patient is pregnant. Chronic pouchitis usually is 4 weeks. It's a combination of antibiotics, using them perhaps a month-long course, Cipro or Flagyl, or the rifaximin in that case. I also use the probiotics, and it could be the VSL3 or Visbiome. And it must be those because they are 900 billion bacteria. It has a wide, range of bacteria, and it is shown that it's more effective than placebo for maintaining pouchitis remission. It's also not something that's going to happen overnight. It's going to take a longer time of being on it, but that can be effective in sort of helping to prevent it. Budesonide rectal enemas, similar efficacy to metronidazole used for cuffitis. And if needed, and we're having this chronic stuff, then we got to move into the biologic area, vedolizumab or ustekinumab. Probiotic use, again, here are the two that I've used. They've been well researched, and it does show they can be effective. I start patients on, obviously you're going to give them the antibiotics. I also asked, hey, if they're on an antibiotic, can we start this or do we have to have them off? And they said, no, it's okay because it has so many bacteria in it, but we want to get them off. And so toward the end of their cycle or whatever, get it started as much as you can. And the main thing they found is it does improve cell barrier function, the barrier wall. Dosing, 1 packet BID, maybe for like a week or so, and then they could go to 1 packet or sachet daily. And I usually tell them at bedtime, that's when they're holding the stool in longer. Here's an algorithm for acute pouchitis. I'm not going to run through everything here, but it shows when you get it, what is the testing. Oh, and you definitely want to check. If they're having a lot of diarrhea, you may want to do a stool test too for C. diff, just to be sure they don't have that. If you say it's active pouchitis, then we move into the antibiotics. If it was C. diff, you do the vancomycin or whatever is treated for the C. diff there. And then you look at your response. Infrequent relapse, antibiotic responsive pouchitis, use the antibiotics PRN as you need them. Frequent relapse, antibiotic dependent pouchitis. Think about also adding in a probiotic and maybe a low dose antibiotic if that will work. If there is totally no response, antibiotic refractory pouchitis, you've gone through all those, of using the antibiotics for an extended period of time, then you look at, is there a response or is there no response? And you have to make sure there's no secondary causes, obviously, like being on NSAIDs, or do they have a stricture there? They've been holding stool in there or whatever. And then you move on, obviously, to the immunomodulators and the biologics. And I can tell you, I had one situation where, so they're supposed to follow up with me every 3 months and then 6 months that next time and then yearly. Well, you're going to have some patients who fall off and just don't, oh, I'm feeling good. I think I'm doing fine. Well, then I'll get a phone call and he'll say, hi. And I'm like, yeah, hey, where you been? Well, I said, what's going on? Well, my wife and my mother told me I should call you. Really? I said, what's going on? Well, I've probably been having like 15 to 20 bowel movements a day. And I'm like, what? What? What are you doing? And he goes, I know, I know. And I said, well, you know what? Now you have probably some chronic pouchitis going on there. And I said, I know that's what you got going on. And I'll get him started on an antibiotic. And it took me 9 months to a year to be able to get him off an antibiotic, but I did. And he's been okay, but he's showing up now. C. diff pouchitis, mentioned that before. Consider if they're having a lot of recurrent pouchitis, you might want to rule that out for sure. Risk factors for it are male gender, pre-surgery left-sided colitis, previous hospitalization, pre-surgery antibiotics, and treatment is vancomycin or the other meds that they have out there. Cuffitis, what is it? It's in that retained 1 to 2 centimeter of rectal mucosa with inflammation. It's just ulcerative colitis in that cuff, or we call it the anal transition zone in those stapled anastomoses. Symptoms, anal bleeding, severe urgency, and tenesmus. I mean, it's so irritating. Diagnose it with a pouchoscopy, treat it with 5-ASA kinase suppositories, Rouse enemas. Then if you have to, you may have to move up to a steroid, proctofoam, cord enemas, Euceris foam, may need an oral. And we did get to that with some person, and those were the ones that eventually said, you know what? I'm not going to deal with this. I want it out. I'll take the stoma. Stenosis, that's that narrowing at the ilioanal anastomosis, pushing hard to have stool, they feel constipated, decreased bowel numbers, amounts, cramps in the pouch, because it's backing up and they only are passing maybe liquid stool. And that's where you need to do these digital exams to check it. If you can get your finger into the first knuckle, that's good, because it feels, when you do a digital exam, it feels like a ring, like there's a ring there, and then you get beyond it, then you're in the open pouch. So you want to always check that. If you cannot get your finger in or it's too painful, then they need to go for an exam under anesthesia and anal dilation, and we have to stay on top of that. There are some patients, I have a few patients, they have to self-dilate at home. For some reason, it just tends to narrow down or whatever more frequently. And those are the ones they kind of learn to self-dilate at home. But that's a very, very small amount. Most patients, once we dilate it and we consistently doing it periodically, it stays open. You can get it proximal to the pouch too, like above the pouch. And those symptoms are more obstructive type symptoms of abdominal bloating, pain, nausea, and they definitely have decreased bowel movements because things aren't moving into the pouch. They may need the exam under anesthesia with a balloon dilation up there. If it's Crohn's disease related, then we're back on medical treatment. Sexual function, my mantra, just ask. Infertility relates to the fecundity. They can carry a baby to full term. There is no issue with pregnancy. Scar tissue blocking the fallopian tubes can be an issue if there's, scar tissue in that area. Refer them to a fertility specialist. I usually wait 6 months, like I said, to a year to tell them to become pregnant. And again, the C-section is recommended, especially if high-risk delivery or an episiotomy is any consideration. Dyspareunia, over time, pelvic floor tissues can soften and relax, and that can improve. If not, I send them to a pelvic floor specialist for the treatment. They do the myofascial release, exercises, relaxation therapy, and couples counseling. I have husband and wives, that go to counseling together on that. Male impotence, decreased erection. Again, that takes time. I give it 6 months. If not, refer to a urologist, and those performance enhancement drugs work. Fear of passing stool during intercourse. I always tell them, go to the bathroom to empty the J pouch before sex. Psychosocial issues, quality of life. Most are happy with the results. Depression, they may feel sad, no energy, sleep a lot, lack of pleasure, suicidal ideations. They're let down if the bowel function is not what they expected, so you got to assess for that. The anxiety, coming to visits, socializing, going out to eat. Initially, if they're having issues, it takes them a while to get over that and say, oh, okay, now I'm okay. I can do some of this stuff. Post-traumatic stress, that's again with chronic disease. Your young teens and adults, they get flashback of flares, hospitalizations, anxiety, and suicide in teens and things. You really have to watch these issues. And these visits, they do take more time for the visits, because if you get into all these psychosocial issues, or have to send them to get on antidepressants, anti-anxiety meds, and always refer them for psychosocial behavioral counseling. Here is my follow-up. Initial adjustment phase, which occurs in the first year, visits every 3 months, then at 18 months, and then 24 months, and then yearly to assess pouch function, progress, or complications. At yearly visits, I usually have them get a pouchoscopy with biopsies. It's very important. We need to assess for inflammation, cuffitis, or if there would be, some dysplasia in that cuff or whatever. And the main thing is that you really need to have someone do these scopes that understands how to do them. We want a biopsy above the pouch, because that's where Crohn's could be if there's inflammation up there. So we always want to check that. Within the pouch, all the different areas and the cuff. If there's inflammation or dysplasia noted, we're definitely going to do another one in a year. And just to check that's okay. You could do also maybe in the not, if you don't want to wait for a whole year or something's occurring, you can also check for inflammation doing a fecal calprotectin if you want. Normal pouch biopsy, like I said, every other year to 3 years based on their risk. So if I go through, they have a couple pouches, they've not had any pouchitis, we've not had any issues, then we can skip a year or two. Fecal calprotectin, like I said, you can use that in between, so you're not doing scopes all the time to assess for any inflammation or improvement in your treatments. Additional visits or assessments if they have problems or feel they have had some pouchitis symptoms, then I will see them and additional visits if needed. And I do some video visits with these patients too when I don't need to be doing specific assessments. Like in that first year, I don't. But after the year visits, moving on with that, I will send them for a scope, get everything done, and then maybe do a virtual visit after they've gotten all their blood work done, that I'm checking vitamins, minerals, iron, folate, all these different things, and they get the pouchoscopy done. I get the path report back. I will then do a video visit with them to go through everything and plan moving forward. So why routine J-pouch follow-up? J-pouch function improves over time. The pouch adapts, and there's all kinds of changes, and the patient needs to self-manage. Patients forget what is good J-pouch function over time. You know, after they have this, the gastroenterologist will like, there's no colon really left or anything. And the surgeons are like, well, they don't need surgery again here right now. So that's where I came in when I learned all of this. And I think this is a perfect role for APPs to follow these patients, because sometimes they refer patients to me that don't get this follow-up, which is so important to help them get adjusted. And they need encouragement, support, and education. Normal pouch expectations, know what the goals are, understand the complications, self-management techniques like Imodium, using the antidiarrheals, working on their diet, make sure they're eating foods to thicken, etc. And adherence to follow-up visits and to call. Remember that little my expectation thing? I give them that. And I tell them they must call me when they deviate from those expectations. And I will work with them to decide, is this really pouchitis or is this something else? So I tell them they have to call. They can't be waiting a week, 2 weeks, because the earlier we get the pouchitis under control, the better it is and easier to treat it. And then the emotional health. That's something that is ongoing. So take-home points: increased awareness of pouch complications, particularly the pouchitis. Follow patients close the first year, and yearly lifelong is indicated. Function improves over time, and remind them it's not all is wonderful and great after surgery. It takes time. Assess pouch function each visit, and 90% of patients are happy with their results and would recommend. And then surveillance of the pouch, you want to assess pouch function and quality of life at each visit. Digital exam of the anastomosis, perineal skin assessment, yearly surveillance with blood work, and the pouchoscopy to confirm pouchitis, Crohn's, cophitis. Yearly, if in the last year they've had pouchitis or they've had cophitis or they had a neoplasm, then we need to keep on top of them. Can check a CRP, fecal calprotectin, in between scope to assess inflammation. And if there is a dysplasia risk and you've checked it, depending upon how much of a risk you think it is, they could have a 3-year assessment of the anal transition zone. But every year, they still have a visit with me to check function and quality of life and do the, the assessment. That's a given. And here's my mantra as well: respect the pouch, and that's prime real estate down there in the anal area. And here's my patients being funny. They send me the respect the pouch. It's a Capri Sun container that they're trying to show we're going to respect the planet too. And then here's another one that sent me this: the power is in the pouch, another Capri Sun.